So we have many questions that I received. The first question is for, I think, Dr. Zuhair Awan. The question is, should lipid profile require patients to fast? And if so, how many hours? I think you answered that question during your presentation, but maybe just a brief for our, we have, I think, more than 2,000 physicians and healthcare professionals registered in this event and watching us live now virtually. Just
Yes,
a brief.
thank you
on
very
the
much for the
fasting and
question.
non-fasting.
I think it's a very important question. We have to shift, we have to move on from, requiring patient to fast all the time. I mean, a lot of patients were been sent home because they have not fasted for the lipid profile to be done. And actually, if it was only test to be done, they should be allowed to do a non-fasting lipid profile because there's a lot of use. There's a lot of application that you can use it for screening. So for screening is an excellent tool. If it's normal, so it's a very, rule out test. If it's abnormal and you're thinking this patient might have hypertriglyceridemia, then you should fast the patient between 10 to 12 hours, not less than, the range is between 8 to 14, 16, but the ideal would be 10 to 12 hours to get rid of all of the chylomicrons and diagnose if you have hypertriglyceridemia. But
So you always start with a non-fasting.
the non-fasting actually is a very useful for all of our purpose.
Because
to treat
most
the
of
patient.
our patients, they come to the clinic non-fasting, and instead of sending them away, you just do the profile, and then after that, if you need to do a fasting one, you order it at a later stage.
Absolutely.
Second question, I think, is also for you, or maybe Dr. Muhammad could take this question. Should all diabetic patients be on statin, and age? And what age is the initiation age for that? So maybe Dr. Muhammad can take that question.
Thank you very much for this question. Actually, we have a lot of patients diabetic, and they have hypercholesterolemia. And I think we have to concentrate on the lifestyle changing. It's really important, and it has a value. Not like familial hypercholesterolemia. It's difficult by only lifestyle to improve their.
So you mean the secondary hypercholesterolemia
yes.
is affected primarily by lifestyle changes?
By lifestyle, and then we cannot. And also in diabetes, it's important and crucial to control diabetes. So concentrate controlling diabetes with minimal doses of insulin, because also increasing the doses of insulin will increase the hyperlipidemia. So it's better to control diabetes with minimal insulin doses. Then, if for 6 months not well treated, then we can go to statin and and I think majority of patients, they will improve on statin. Regarding the age, in children, we cannot start statin unless he is 8 years and above. Before 8 years, it's not recommended yet, and it's not
8 years.
8 years, yes, 8 years. So from 8 years we can, but we really insist on lifestyle changing and controlling diabetes on as much as minimum of insulin doses in children, and then we can move to statin.
Yeah, so in the pediatric population, if you have a patient that has an abnormally high LDL cholesterol, or and in a combination with diabetes, do you label him immediately as FH and start combination therapy, or do you start with statins?
No, if he's secondary, you mean?
Secondary.
No, secondary, usually we label him as secondary. So because of the diabetes, because as we follow the patient, actually in children, if it is persistently high cholesterol, then I can diagnose him. But
so that's something very, very important, that secondary also exists in the pediatric population.
Yes, it is there. It is there. Actually, still, last week I saw some patients, they have LDL4 and something, more than 4 even, because of diabetes. From the beginning, for 2 years, 3 years, it's not even exceeding 3 millimole. But now they have 4 point something. So secondary is there in children with diabetes. And I think
Fantastic.
Dr. Muhammad will
I have-
speak about the treatment later.
I have a question for Prof. Al-Judea. I saw your presentation, really impressive presentation. And one of the slides, you mentioned that the clinical trials is also an added income or added value from a monetary point of view to the country, as well as your innovative project for the FH registry. You can monetize that for real-world evidence and real-world data, provided that you do have an accurate way of obtaining data, an accurate way of validating the accuracy, and of course, organizing and analyzing. What's your thoughts about real-world evidence, real-world data, and venturing into the effectiveness of the different medications on the Saudi population, and tying that with pharmacogenetics and tying the whole chain of phenotypic imaging and genotypic information?
Great. Thank you very much, Dr. Adel. These are very important questions, but you asked about almost 3 questions in one, so I'll try to address them really quick. Real-world evidence generation is extremely important, not only to understand the phenotypes of the disease that we have, how patients respond in terms of their genetic makeup, and different aspects related to the difference of controlled environment in clinical trials versus real-world practice. But also they are important, as you alluded to, for generating revenues indirectly. I'm not talking, when we talk about generating revenues, not necessarily you sell the data to researchers. It's actually getting grants so that you can mine these data and get more insights about certain aspects, whether they are genotyping and relation of the development of that particular disease, or severity of the disease, or the different phenotypes that we have of that particular disease, how they respond, the post-marketing surveillance, side effects, adverse events are extremely important. And you could get grants from industry, from National Health Institute of Health, from different grantors, universities and research centers. And then you could actually use this grant to employ Saudi practitioners, Saudi data analysts, and many others. And this is how we are using data, real-world data, as a mechanism of funding certain projects. The other important thing, I think the clinical trials themselves could generate revenues, because by participating in phase 2, phase 3 clinical trials, you could actually attract the industry, pharma industry, into having more visibility to the Kingdom of Saudi Arabia as one of the participating centers or participating countries in generating new evidence using clinical trials. I believe that we haven't been doing great job with this regard as a nation, as a country. It's time now to utilize this. We have the minds, we have the infrastructure, we have the vision. Actually, the vision calls for this to, diversifies our economy and also focus on clinical research. There are multiple ways to generate data that suits our country, and also guide the decision-making in terms of developing our own guidelines, our own clinical pathways, but also generate more income so that we can utilize it within the healthcare continuum.
Thank you very much, Professor Judea. I think this is a call for researchers from all over the country to come to think about what are the areas of research that they want to, what are the questions that they want to answer, Grants are there either from the industry or from the Saudi NIH, as Professor Jadea mentioned. And we do have a huge registry. We have more than 5,000, 6,000 maybe now, patients with full clinical information. So it's a treasure that needs to be really well benefited from. So there are many questions. Let me just check about the patient pathway for suspected FH patients. This is also for Dr. Muhammad, maybe. What is the pathway? Can you describe it in a one sentence or briefly, the pathway for a suspected FH patients? How are we dealing with those in the ministry? What is the algorithm? What are the steps? And then the phased treatment approach that you mentioned also in your presentation.
Thank you. Actually, the pathway starts with suspected case. If you're suspecting that patient has familial hypercholesterolemia, so should be examined by a specialist, like endocrinologist or cardiologist. If you confirm the diagnosis, then he can ask for the medication centrally, and it will come. There is a registry. They should register the patients and put all the criteria. So, and then the medication will go to the patient. As also Dr. Ahmed mentioned, that it will be value-based. If there is improvement, he will continue the medication. If it's not, then we will, there is an almost weekly meeting in the steering committee to discuss all the cases, whether they are new cases or old cases, and see if the patient really fulfilling the criteria. So we will continue the medication, like PCSK9 or ezetimibe, so we can continue the treatment for the patient. So it starts with suspicion. Maybe the suspicion may come from the family physician in the primary health center. Then he will send it to a specialist like cardiologist or endocrinologist. If he proves the diagnosis and fulfilling the criteria, he can register the patient. Then it will come centrally, and the medication will be available for the patients.
Thank you very much, Dr. Muhammad. Question for Professor Awan. When do we use pempedoic acid in the treatment of FH?
Okay. First of all, it's not high intensity statin. It's not high intensity medication, so we don't actually resort to it as a first line. It's usually when it's in a phase of statin intolerance, we move on to see other alternatives. So because the percentage reduction is not huge, so we don't reach target as soon as we want it to. So it's not the first line. It's usually in the context of statin intolerant, and it's in combination with ezetimibe or.
So another question. Thank you, Professor Awan. So about omega-3, you can take that question as well.
Yeah, omega-3, I mean, it's again, we don't have a drug that is registered that has the very high yield omega-3 in the pharmacy so now. So again, the first line was fenofibrate. Then if the patient is persistent hypertriglyceridemia, then of course you have to control his diabetic. If he's diabetic or pre-diabetic, you have to reduce the weight, start a fenofibrate. Then you would use omega-3, and the doses between 2 grams to 4 up to 6 grams. Again, I haven't seen any very high yield omega-3 in the market that I can rely on. But again, it's one of your alternatives.
Another question for Dr. Muhammad. Thank you.
Maybe I can just add one thing.
Yes.
There's a misconception. A lot of patients who have familial hypercholesterolemia, when they go to dispense their medication in the private sector, in the private pharmacy, they will offer them omega-3 together with statin. Yeah. And there's no evidence basis for this. So please discourage this practice. There's no relation, there's no benefit of adding fenofibrate to a statin. Yeah. I hope, again, the Saudi Society for Clinical Pharmacy would advocate not to misuse this medication because there's no evidence for this and so on.
Yeah, it's very popular upon
I get a lot of patients
Yeah, popular upon the general because they liked the alternative medicine approach, and there's a lot of talk about it in the media, and maybe Professor Judea could comment.
Yeah, I would like to thank Professor Zuhair for highlighting this. This is actually one of the, I would say, practices that are not based on evidence. And it comes actually more of a medical myth that combining these agents would actually result in better outcomes. We have worked on a program called Choosing Wisely, part of the overall scientific societies under the auspices of Saudi Commission, identifying these practices that are not supported by evidence or practices that are continuously seen in day-to-day practice that evidence supports that evidence exists to, that these do not work or are harmful. So one of the things that we are going to work on, we have worked on 10 Choosing Wisely initiatives. I think this one could be one of the things that we work on. I think another thing is to educate the GPs in the private sector. They tend to prescribe omega-3 for almost every patient with dyslipidemia. So absolutely, yes, I agree with Prof. Zuhair, and we are going to put it in our second phase of Choosing Wisely initiative.
And if they do prescribe omega-3, it's always out of pocket from the patient.
The problem with omega-3 that we have, these are the food supplement type of omega-3. It's not the high yield omega-3 that has been studied in clinical studies. And hopefully we'll have, one of the newer high yield formulations added. And they also, when they are added, they need to be used according to the evidence, not for all patients. So part of it is misconception, part of it is practices that are not based on evidence. So education is very important. And there are also marketing issues with this. So, marketers of these food supplements that are not high grade yield omega-3 derivatives also is an issue.
Thank you. Fantastic, really, really informative. Professor Awan, you talked about premature heart disease in patients in the 30s and 40s. I'm a cardiac surgeon by practice, and I just was telling Dr. Jamila, I just operated on a 40-year-old gentleman, CABG and AVR, just last week. So just tell us more about how does dyslipidemia or familial hypercholesterolemia cause premature heart disease, and how can we modify that because of the large percent of our patients in the category of dyslipidemia and the possibility of having premature cardiovascular disease.
Excellent. Again, this is the whole purpose why we're having this conference is to increase awareness and have a really a huge impact on the society. So premature cardiovascular disease is mainly due to a genetic disease like familial hypercholesterolemia, because you don't see actually the effect until you have a whole atherosclerotic vessel or calcified vessels. Therefore, patient have the disease going on since birth. So it's a silent disease. You have abnormal high lipid levels in the blood, high cholesterol in the blood. So the process of atherosclerosis starts very early on in childhood. That's why we want to diagnose patient and very early on. We want to go into the family, screen the whole family, look for all of the individuals who are suspected to have familial hypercholesterolemia to really start the management. The management start with, first of all, the right diagnosis, then lifestyle. You have to educate those kids not to smoke, adopt a very healthy lifestyle, and then start medication as they are, old enough to start medication. And the medication is for life because this is a genetic disease. Therefore, you don't stop. This is not an antibiotic course that you start and then end. It's a lifelong disease, so therefore it's a lifelong management.
Yeah, and I think what I am noticing in this young population is that the first or the predominant risk factor for cardiovascular diseases, and the first to appear really with the patient, is the dyslipidemia. There is a question for Professor there. Probably this will be the last question for our Q&A. Is when can we see results from the from the registry? And so basically, what's your plan? Is it going to be results that are published? So it's going to be a research type of results, peer-reviewed and published, or are you going to release executive reports from the Ministry of Health?
Great. This is a great question. So our registries are not national level registries that are designed for epidemiological purposes. These are more for therapeutic purposes, meaning these are not disease registries. It's more of a drug disease registry. So absolutely, there are huge potential for generating evidence from these registries. We're working currently on PCSK9, our experience with PCSK9 inhibitors in management of heterozygous familial hypercholesterolemia. The other thing is the high-dose statin in combination with the ezetimibe. We also have lomitapide for homozygous as part of our registry. And if inclisiran is added to the MOH formulary, it's going to be part of the registry. So being able to report the effectiveness of these agents in our population is a must. We really have to do it. Now, the first project that will see the light, hopefully, is the PCSK9 inhibitors.
Fantastic. Thank you very much. This is a great session. There are some questions that I know that the answers to those questions will come in the upcoming sessions, so please stay tuned for the next talks. Thank you for our speakers. I really enjoyed all the talks, and looking forward for the session after prayer, or now, or what? Now? We start right away. Okay, thank you.